down closer to be a bit more part of the action. My name is Alice Armstrong. I lead on adolescent sexual reproductive health and HIV at the UNICEF Eastern Southern Africa Regional Office. I'm also a long-time fan of the Zvandiri's work. So it's an absolute privilege for me today to be facilitating this session and to be joined by so many people that I admire in the space of adolescent sexual reproductive health and also adolescent HIV. So we've heard this week, and we all know the reality that AIDS is not over. And this is especially the reality for adolescents and children. 4 decades now into the HIV epidemic, and adolescents continue to experience poor treatment outcomes, as well as high levels of mental health challenges. The good news is, though, that we have the solutions to ensure that adolescents not only survive, but they also thrive. You will hear today from a range of experts from academia, from government, the UN, from young people themselves, that we have the policies, that we have the evidence, that we have the experience. But now it's time for us to scale up and reach all adolescents and young people living with HIV. It gives me great pleasure today to introduce you to the first speaker, Dr. Owen, who is the director of the Zimbabwe Ministry of AIDS and TB Unit. Welcome, Dr. Owen. Thank you.
Thank you very much, and good afternoon. Good afternoon. Yes, a warm salute to all young people in this room. And I think this is your opportunity, and this is your time to lead. Because 30 years from now, I'm sure you'll be in my shoes. So I can tell you from experience that you need to take charge as of now. It gives me great pleasure to be with you this afternoon. And of course, we know we are all celebrating, and we're also happy that we've made so much stride in our fight against HIV and AIDS. You have probably heard that a number of countries in Africa have reached the 95, and a few more are about to do that. But however, the disappointing thing, and with great concern, is that young persons have been left behind. Young persons and key populations, the rate of infection continues to rise. We do have gaps, and we need to make sure that we address them. We also know that young people have poor access to HIV and AIDS services. They have poor adherence, and this might also lead to virological failure. And also, we are also worried about the high rates of depression, anxiety, and suicidal ideation amongst the young people. We need, therefore, to make sure that we treat our young people and provide them with a full life and make them happy too. And as we continue with our treatment strategies, we need to make sure that we integrate HIV and mental health, and drawing on experiences that we have gathered amongst young people. We know that in Africa we don't have much resources, but I can tell you that we are very rich in resources when it comes to the community heart, spirit, and soul. And we should use that to make sure that we care for our young people. I also remember that some 20 years ago, colleagues from Zvandiri came to see us, and we discussed around the issues of setting up support groups in Harare that would complement the care and treatment that we're then providing. And we agreed that this would be a children and adolescent driven model. And early those days, it was very clear that the children and adolescents had clearly told us that they needed more than the medicines that we were providing. And with that, we sought to have the Zvandiri model that puts young people at the center and also makes sure that the programs and activities that we were providing were led by the young people. You will, of course, hear during this presentation a lot of the experiences that we have had with the Zvandiri program. And of course, I just want to say that this is a Zimbabwean-born model that we scaled up, and we are happy that we are beginning to share it with the whole world. It doesn't belong to Zimbabwe. It belongs to all of us and all the young people in the world. So I do hope that you'll be able to copy and you'll be able to adapt some of the things that we have done in Zimbabwe. I'm also happy that initiatives like the Global Alliance to End Pediatric HIV and AIDS is calling on us to accelerate action to close the gap for children and young people. Zimbabwe is a member of this UN Special Initiative on Mental Health for young people, and we hope that we can also contribute and assist in the strengthening of the mental health response. We therefore appreciate and deeply value the power and the strength of our young people in making this a reality. I thank you very much.
Wonderful. Thank you, Dr. Owen. We know you as a true champion of young people for believing in their contributions that they can make, and that with your team, you've shown Zimbabwe, the region, and the world what young people can do when they're given the opportunity and the support. So we thank you. Let's give them another round of applause. Great. I'd now like to introduce our next speaker, Dr. Sarah Benese, from the University of Sydney and the London School of Hygiene and Tropical Medicine. Sarah will be presenting on behalf of a collaboration of researchers, including Professor Francis Cohen, Dr. Webster Mavu, herself, Nicola Willis, and all the way back since 2009, they have been really working hard to make sure that we have the evidence that we need to inform our programs and our policies when it comes to adolescents living with HIV. And we all as the region have really benefited from this evidence and understanding. So let's give Sarah a round of applause as she comes up to present. Thank you.
Thank you, Alice. And it's an honor to be here in front of each of you. Thank you. And as Alice said, I'm speaking on behalf of many, but especially Nicola. So next slide, please. So as we've heard, while there is much to celebrate at this conference about the progress that has been made in controlling the HIV epidemic and caring for those affected, everyone in this room is acutely aware that this progress is unevenly felt. Adolescents are being left behind, with fewer getting onto ART, they have lower rates of viral suppression compared to adults, and they have a high risk of poor mental health. And we know that there is a relationship between mental health and adherence. They are mutually reliant, and they can worsen each other. But they each matter on their own too, and mental health matters as much as viral suppression. Next slide, please. So the problem persists, though, of adolescents enduring poor HIV and health outcomes, not because we do not have solutions, thank you, but because we are not investing seriously enough in the solutions that work. Next slide. What works is HIV treatment, or ART, plus mental health treatment in the form of psychological support. And if we provide them together, so they are preventing the development of poor mental health rather than just reacting to it, then treatment plus enables improved HIV and health outcomes, including quality of life and happiness, which really matters. And this formula can be delivered at scale to reach everyone. Next slide. So why does psychological treatment support adherence? Well, because it redresses the primary drivers that we know from a huge amount of research. We know that undermines being able to take your pills consistently every day. And these are things like delayed or incomplete disclosure to the young person, the confusion and disempowerment that accompanies having limited knowledge about HIV, and poor mental health. And psychological treatment is an integral part of psychosocial support. What it does is it provides a reliable, trusted space to talk, to be listened to, and be counseled. And the support is person-centered and fosters connectedness. And in being heard and understood, people are, and in being supported, they have a strong understanding of HIV. They appreciate that their HIV status does not need to determine their future, and they can thrive. And it is inviting young people to share in the experience of health, hope, and happiness. Next slide. So, to enable and sustain viral suppression in this population, we should be thinking about treatment plus. Obviously, the first line of defense is ART, but to convert efficacy to effectiveness, it needs to be accompanied by psychological treatment. Next slide, please. So it's worth just taking a moment to ask whether we still need mental health support given how good ART is getting. Dolutegravir reduces the need for treatment to be taken all of the time, but it still needs to be taken some of the time. If someone is struggling with their mental health and doesn't take their treatment, then the effect of the treatment, HIV treatment, becomes fragile too. So there's nowhere to go. We cannot ignore mental health and well-being. And there is an increasing policy emphasis to biomedicalize each aspect of the HIV response. But we don't need a wonder drug for mental health. We have a more affordable, a scalable, and effective and appropriate solution that works. And there are a number of models doing this, but I'm going to talk about Zvandiri, an exemplary model. Next slide, please. And before I do, I want to give a big shout out to everybody here from Zvandiri, you who are the beating heart and soul of Zvandiri, and we see you and appreciate you. So Zvandiri is a holistic model of psychological support provided by trained peer counselors called CATs, who are HIV positive themselves, and they provide support by visiting adolescents living with HIV, their clients, and they go to their homes, to health facilities, facilitate support groups, and access care through digital platforms. And we're also developing wraparound care by developing and testing a caregiver intervention to ensure that the support they receive through Zvandiri can also be reflected in their households. Services are differentiated by needs, and CATs receive professional supervision. Zvandiri is operating at scale in Zimbabwe, delivered by the government. The model enables young people to connect with others. It emphasizes role modeling and relational care. As we know, Zvandiri means accept me as I am, but it works through relationships. I accept myself in part because I admire and accept you. I am inspired by you. I think differently about myself because of how I see you, and I can thrive because I can see that you do. Next slide, please. So if we work from the bottom of the pyramid up, by promoting mental health and well-being for everyone, it operates as early prevention to stop mental health problems developing for the majority. For those who are suffering mental distress and problems, these can be identified by the CATs, and the clients receive enhanced counseling. And where necessary, with acute mental disorder and illness, they'll be referred to specialist care. Next slide, please. Zvandiri has been central in developing the evidence-based practice to shape policy and service delivery. Program data and 3 randomized control trials have shown that it improves HIV treatment and mental health outcomes amongst adolescents living with HIV. The Zvandiri trial, which ran in 2016 to 2019, showed that with the provision of Zvandiri support, there was a 42% lower prevalence of virological failure than in the standard of care, so where there wasn't Zvandiri. This informed the WHO recommendation in 2020 that psychosocial support should be provided as standard for all adolescents living with HIV. And as I mentioned, this has been adopted in Zimbabwe in the national guidelines. Next slide, please. But it's also been delivered in 13 other countries within Africa, reaching 160,000 young people. In terms of research, we no longer need to show that this works. We know that it does. We need a focus on supporting its implementation at scale. Next slide, please. In our most recent research, we've been looking at why Zvandiri works. What is it that means that young people can thrive? And we've identified 6 constructs which operate in a reinforcing cycle. And excitingly, we're going to hear much more about this in the film coming up after me that we have made with some of the amazing young people in Zvandiri. Next slide, please. So we have the evidence, we have the guidelines, we have a really vital solution. It's about treatment plus. It is time to move away from psychological treatment being just a nice extra to it being understood as critical to the effectiveness of our HIV approach for adolescents living with HIV. And it must be moved from the periphery to the center. We can close the gap for adolescents' outcomes through connecting in models such as Zvandiri. And we have the young people with their inspiring energy, enthusiasm, capability, and commitment to deliver it. But we have to be intentional and deliberate about investing resources in it. It is cheaper than many alternatives, but it is not free. And while it's an adolescent model we're talking about, there is plenty of scope to adapt it for adults. So the time is already here to be doing this everywhere. Thank you very much. If I have the next slide and then the next slide after that, please. And now let's hear from the young people in the film. Thank you very much, everybody, for listening.
A daily dose will help us survive. But surviving is not all I need. What I really need is to thrive. So what does thrive mean for me living with HIV?
I need a different kind of treatment for the loneliness, isolation, and fear. A friend to connect with who understands me and cares. That's where I feel safe. That's where I belong. My smile is huge. My heart is full.
This helps me to accept myself, knowing I can truly be me, expressing my true colors with nothing to hide. I can still slay. I can shine and be hot. I can stand tall. HIV does not define me or make me small.
Before, I was lost, but now I know there is life. I know now not to limit myself, as my future is bright.
Now I have the information and the truth about my health and my treatment. This gives me confidence, a settled mind, and the knowledge on what to do.
This helps me to cope. I can overcome the hard stuff. I'm brave, I'm strong, and I'm courageous.
Sharing my story and supporting my peers gives me purpose and pride. I'm a counselor, a leader, and an advocate for my peers, giving back what was once given to me.
I want my story to give others purpose. I now have a future to build, people to help. I have a family, my own true family.
I look back where I've come from, what a journey it's been, but this is me now, just as I am. Beyond the physical success of my HIV treatment, I'm at peace, connected, confident, with purpose, not just surviving, but thriving.
Sharing in the most beautiful, creative ways, right? Your music videos were not enough. Now you're doing poems and performance art. I love it. Congratulations to you all. Such powerful messages: hope, connection, purpose, acceptance. These are powerful, powerful things. Thank you so much to the young people who were involved, not just as participants in research, but as you see, finding really, really exciting and creative ways to disseminating the outcomes and the results. So congrats to all of you. So this week we've been hearing about the tremendous advancements in HIV treatment, which is wonderful. And we just heard from the government of Zimbabwe, from the research, from the young people, from Zvandiri, at the importance of the integration of mental health, psychosocial support, along with HIV treatment. This is critical in our response for adolescents living with HIV. So how can we truly optimize the success of the treatment that we do have access to? And how do we do this? By ensuring the integration of mental health and psychosocial support. So I'm delighted now to host a panel with some excellent ladies. If you would like to come now and join me on the stage here. We have a phenomenal group of experts who are going to share their thoughts on this with us. So if we could first please have Dr. Meg Doherty, who is the Director of the Global HIV, Hepatitis and STIs unit at WHO in Geneva. Give her a round of applause. We have Dr. Judith Mulela, who is from the Ministry of Health and Social Services in Namibia. And we have the wonderful Melissa, who is a Zvandiri Cats, and she's also part of the UNICEF Zimbabwe Youth Council. So welcome to the stage, Melissa. So I think I'm going to come down and have a seat with you rather than standing up here. We've run out of mics, so it's going to be logistically a little bit difficult. No problem. Are you sure? Okay. Cool. All right, welcome. Thank you so much for joining us on this panel discussion today. And I'm going to start off first with Dr. Mulela. So your government has been leading the way in replicating the Zvandiri Cats model and in embedding it into your national systems in Namibia, which is super exciting. We know that there are other countries out there that are doing the same, others that are keen to do this as well. So we've got a lot to learn from you and the process and the experience that you have undertaken. So I'd like to hear from you a little bit more about that experience. So what did it really take to establish the peer-led approach and then also to scale it in districts in Namibia? So over to you.
Thank you so much. Well, the Namibian government has shown strong leadership from the start of the implementation of the NATS program in 2020. The government recognized the significance of the NATS program in addressing HIV-related challenges among children, adolescents, and young people living with HIV, and therefore supported various activities pertaining to NATS program. So this was done through adaptation of standard operating procedures and guidelines that ensured the integration of peer support within broader healthcare initiatives. So CDC is one of the long-term partners of NATS program. Having collaborated with the ministry from the start of this program, they have been providing technical and financial support, ranging from funding the stipends for the NATS themselves. NATS, we say NATS in Namibia, which is cats. Trainings, materials, and practical supplies needed for the program. And furthermore, the government has been allocating resources through the CDC COAG budgets, specifically earmarked for the program activities, and has shown readiness by supporting training programs and human resources to integrate peer support services into existing healthcare structure. So the program also received extensive support from Africaid ZvandiriNAC that included trainings, mentoring of NATS program officers and NATS themselves, and conducting foundational baseline assessments and inline assessments, and delivering comprehensive training sessions to healthcare providers, and guiding on the implementation and utilizing of monitoring and evaluation tools. Africaid also accredited the Ministry of Health and Social Services of Namibia to independently execute the NATS program or the NATS model in May 2022. And currently, as we speak, Namibia has continuously progressed with the program, consistently introducing fresh initiatives aimed at enhancing its efficacy and impact. Currently, in Namibia, we have a total of 51 health facilities running the NATS program. This is in 8 regions out of the 14 regions we have in Namibia. And we have 102 NATS. These are peer supporters, and over 8,000 children, adolescents, and young people living with HIV have benefited since its launch, showing its substantial impact on the healthcare delivery among this population. So in summary, establishing and scaling the NATS program in Namibia really required a strong government commitment, evidence-based approaches, financial support, strategic partnership, standardized technical assistance, evidence-based curricula, robust supervision, and tools for peer supporters. Thank you.
Excellent. Your commitments to this work is very clear, and we thank you for that. And I think for me, what really struck was the range of partnerships that went into, right? From Zvandiri to yourselves, to CDC, to others, to the facilities. It's really fantastic, the amount of people and organizations that are committed to see this integration. So thank you so much.
Thank you.
So we're now going to move on to you, Meg. Thanks for joining us. We've been hearing wonderful progress of the Zvandiri model, both in Zimbabwe and now Namibia, who have adapted and obviously adopted the very important guidelines that were developed back in 2020 around the integration of HIV treatment with psychosocial support and mental health. We also heard yesterday in the Global Alliance session that you chaired that countries are really wanting to prioritize peer-led interventions and psychosocial support interventions. So my question to you is to really understand, what do you think is now needed to turn these plans and these desires really into action and reality for other countries? Thanks, Meg.
Well, thank you. And I apologize that I'm coughing. I really do apologize. I'm not I think I'm in a reactive phase right now. So those of you who live with asthma may know what I'm talking about. So apologies. But I do want to say thank you for having me up here. And it's really impressive at the last few days, we still have such an interest in adolescent work and certainly about the psychosocial interventions and mental health that's so needed. And when we talk about the whole spectrum of continuum of care and healthy life course, it's so key that we're always thinking about what is left behind. And I'm remembering when we started talking about DSD models way back in the beginning, Alice and many others were there right at the start saying, you can't just do the clinical care. You need to include the psychosocial support for adolescents and for children, or we will not have a good differentiated service delivery model. So this has grown out of a long history of working with Zvandiri, working with Alice and UNICEF and others who have been doing this work. And I also want to just to recognize that we do have this, it's nice to have paper, but we do have this recommendation and a policy brief that we can have countries use. So if that's useful for countries to try to take this model to scale, there are some examples there. And a couple of years ago, there was also a document put out that showed how you can take the DSD model and ensure that psychosocial health and psychosocial support and mental health recommendations were part of that. So I think for moving forward, I think this meeting has been excellent to highlight the needs of the Global Alliance to End AIDS in Children. But that's also about adolescents, because we know that there are many children who go into adolescence who also may not be getting the support and care they need. And this kind of intervention and these kinds of CATS models that are around the client center, we believe are the kind that will help us show in the end that we're able to, end AIDS by 2030, but also ensure a long livelihood and positive livelihood for young people. So what do I think are the next steps to get this out to other countries? I think it's about these kinds of interventions, these kinds of situations where you're sharing. There needs to be extra going into countries and maybe looking at how both Zimbabwe and Namibia have adopted the models, maybe some self-to-self visits to be able to learn. We know that many people have come to Zvandiri to be able to learn exactly what the CATS model offers. Clearly, these are the kinds of things that should be written into PEPFAR country operational plans, Global Fund concept notes. But I think more importantly, this is about adolescent-friendly health services, so should also be in the MNNCH program, should be brought to ministries of health, should become something that's actually integrated into a longer-term vision for healthcare for young people. Because I'm sure it's not only going to benefit for HIV, it's going to benefit for the other diseases and other health issues that young people are dealing with, whether that's sexually transmitted disease, another big topic on the agenda today. I think the other thing we'll need to do is to monitor and show the successes, using whatever data comes out of the programs to show this helps. This is cost effective, potentially, but this has an implication for the long-term outcome for those people who are involved in the program. So those kinds of data points will also be very helpful as you move forward. I'm just really excited to be here, and thank you for inviting me here, and really well done and excellent work. We always love to see what comes out of Zimbabwe and the CATS model, and now the NATS model. Thank you.
Thanks, Meg. So making those guidelines a reality, we really need to be leveraging the big money that is around for us to really fund and implement these models. Thank you so much. And your commitment and WHO's commitment to ensuring that we have the guidance that countries can act upon as well. We appreciate it. Okay, Melissa, over to you. You are on the ground. You are doing the work. We know that it works. You see it every day in the work that you do. Tell us, what else do you think is needed for us to reach all adolescents living with HIV? We want to hear from you.
Thank you for the opportunity that you have given me. And I think all of us, based on the video that we have seen, we can all agree that young people are bloomers. that we can do things and we can make it possible. I think we all can agree with that. So before I say anything, can we please give another round of applause for these young people that did a great job? Thank you. So, based on the question that you've given me, I believe that making use of awareness campaigns can be of great help for us young people to connect with other young people who are out there. Why am I saying awareness campaigns? I'm saying awareness campaigns because they are part of an education where we educate other young people who are not aware of what HIV and AIDS really is, what viral load really is, what antiretroviral drugs can do. That's what I think. And when we're saying we are hosting awareness campaigns, we're saying we're going to hotspots where we can find other young people, we can reach out to them, we can make use of sports, we can make use of art, we can make use of anything that can engage young people, that can make them feel at home, and they can be expressive, and they can tell us what they really want from us, what they really want for us to do for them. And also, we can make, since we're in a digitalized world, we can use platforms, Facebook platforms, Instagram. I'm sure young people do agree with me with this. That's what we're using nowadays. We use them to make campaigns, we use them to educate people who are in that digitalized world, for them to know that, yes, you can do anything. So when we're making use of digital platforms, right, we are training people. Maybe we should train people using those digital platforms to be advocates, to relate to other young people, that they can do it, they can, that every young people can have services to HIV and AIDS at any given time. And also, I wanted to talk about the community adolescent treatment supporters. They really do a great job in terms of reaching out to other young people. So I feel like it's high time we officialize these young people. We have healthcare workers, yeah, right? Those old healthcare workers. So maybe we should recruit these young people, make them the healthcare workers, right? And then we fund them in terms of giving them resources to reach out to other young people. What I'm saying, let's take an example of remote areas. We have remote areas, marginalized parts of the country. That's Cholocho, Musarabani, we have Wange. I'm sure most of us know those remote areas. So for community adolescent treatment supporters, we offer bikes so that they can, for transportation services, they can go as far as some other parts of the area to reach out to these young people, check on them, teach them. That's what I think should be done. So this is a plea. Before I summarize, and this is a plea that let's take account of young people, the community adolescent treatment supporters, and recognize them so that they can give out, so that they can teach people, and we can have more advocates for HIV and AIDS. Thank you very much.
I think we have a young peer healthcare worker revolution on our hands, hey? Exciting, exciting stuff. Thank you all to our panelists. Another round of applause for them and their insights. We all know after this week that 45 minutes goes so quickly. We are almost out of time, but time is flowing. But it's evident that there is so much for us, not just to learn from each other, but there's still a lot of work that needs to be done to make sure that we have the integration and the support that young people need to really, truly make sure that that ART is successful for them in their lives, right? For them to thrive. Don't you love the sign? Yes, beautiful. So, but before we come to an official close, I'm really happy to introduce Dr. Mazima, who is from the National AIDS Council, where he is the director in Zimbabwe. He is here today joining our session. Thank you so much, sir. We would like to invite you to the podium. Thank you. But just quickly before he speaks, I just want to applaud Dr. Mazima and his team for making the pioneering decision 4 years ago to use domestic resources to directly fund cats. I think that deserves a massive round of applause. So he has demonstrated to governments around the world and in our region, that where there is a will, there is a way, and that young people can do the work, again, given the opportunity and the support. So over to you. Thank you.
Thank you, the moderator. Good afternoon, everyone. Let me start by saying thank you, Melissa, for the old healthcare workers, because I'm one of them. We really want to work with young people. I think it's important for mentorship and it's important for growth. So, as an organization, National AIDS Council deliberately has adopted that approach. We now have a program for graduate trainees where we emphasize that they should be taught the skills by those of us who are getting out of the system. My job here today is to really thank everyone. And I want to start by thanking all of you for coming to this session, noting that it's now Friday and that some people might actually think that the conference is over, but you have taken time to be here and to hear this exciting program of Zvandiri. I want to thank the panelists who have taken time to come and share their knowledge on the subject at hand. And what are the issues? If we are going to forget everything, for those who are in positions of making decisions, the issues, as far as I understood them, and as far as I understand the program, is that we need to increase access of sexual reproductive health services to young people. We need them to stick, we need to talk adherence to arts. We need to talk mental health. So if you are going to forget anything, just remember that this is what it is all about. But we have issues of inequality, especially concerning the adolescents, in terms of access to sexual reproductive health services. So we need to address that. We need adolescents to be able to access effective treatment. But more importantly, we know the issues around mental health. They transcend and, amongst adolescents, and the causes are many. And but we need to address those things. If we don't, then all the gains which we have talked about will be put to waste. So Africaid ZvandiriNAC, the model, I think it's good that they started, talking of they're integrating mental health and HIV and NAC. We really support that. There's commendable work which has been done. I'm happy that my colleague here, Dr. Mgurungi, is here representing ministry. He is an ancestor of HIV. HIV. So we work with this team as a National AIDS Council. We work with partners. I want to acknowledge WHO, Meg Doherty here as well. She has done tremendous work for the country, but not only for Zimbabwe, for all the high-burden countries. And she's always available to share her knowledge on the subject. So I want to applaud that. We will continue to support the CATS program, and we really want to make sure that we support it. I'm also urging young people to come up with innovations and be able to write proposals and bring them to National AIDS Council. We want to support research. You don't just write proposals when you want to get your degrees. Write proposals so that you do programs. So I will not take much time. Again, let me thank everyone for coming to the session, and in particular, but for coming to ICASA in general. I think we have not done the figures, but I think it has been a successful ICASA. Thank you.
I didn't realize I got another word. I thought that was it. So I think maybe for me the parting will be that AIDS is definitely not over for adolescents until we integrate and we scale mental health and psychosocial support. So we have the evidence, we have the experience, now we just need to go and scale it up. All right, thank you everybody. Enjoy the rest of your ICASA.
I'm not a stranger to the dark. Hide away, they say, 'cause we don't want your broken past. Broken. Learn to be ashamed of all my scars. Run away, they say, no one will love you as you are. But won't let them break me down to dust. I know that there's a place for us, for we are glorious. When the sharpest words wanna cut me down, I'm gonna stand the flood, gonna drown them out. I am brave, I am bruised, I am who I'm meant to be. This is me, look out, 'cause here I come. And I'm marching on to the beat I drum. I'm not scared to be seen, I make no apologies. This is me.
hapa, kuja hapa.